I'm Dr. Corey Cutler. I'm the director of the stem cell transplantation program at the Dana-Farber Cancer Institute in Boston, and a professor of medicine at Harvard Medical School. Today, we'll be talking about second and third line therapy in steroid-refractory chronic graft versus host disease. Unfortunately, even today, with good drugs for the prevention of chronic GvHD, we still have a number of patients who develop chronic GvHD, and at least a third to a half of our patients will actually end up requiring second line or third line agents for their chronic GvHD. We know that patients who don't respond promptly to corticosteroids or to those who progress despite corticosteroids will require second line therapy. We do have standard definitions for steroid refractoriness. Most of them involve being on corticosteroids at a dose of 0.5 to 1 milligram per kilo per day for a few weeks, or patients whose chronic GvHD is stable on their therapy, but who we can't wean. And that's more a definition of steroid dependence. When we're deciding on who requires second and third line therapy, a lot depends on looking at the patient in front of you. Patients who have obvious progression in organs such as the fascia with myofascial contractions and sclerosis, these are the patients who we're more apt to move on to second and third line therapy quickest. Those with things like low degrees of skin involvement or only lichenoid changes. We'll give patients like that a little more time, often several weeks to even a month or two, to have the best chance at their response. It's really about understanding the morbidity of the patient's chronic GvHD and how it affects them when we determine if the patient requires second or third line therapy. Currently in the United States, we have 2 drugs that are approved in the second line for chronic GvHD therapy, and an additional 2 drugs that are approved in the third line. The first drug approved was ibrutinib back in 2017, which is a BTK inhibitor. It's approved in both the adult and pediatric space based on the original 1129 trial for ibrutinib in adults and the Imagine trial in kids. Ruxolitinib was approved on the basis of the REACH-3 trial, which was a randomized study. In fact, the only randomized trial that we have in chronic GvHD with a control group. There is more recently the REACH-5 trial in kids that allows us to use this drug in younger individuals. Then in the third line, belumosudil was the first drug approved, belumosudil being the ROCK2 inhibitor. This is for individuals above the age of 12, and this drug was approved on the basis of the ROCKSTAR study. And then very recently, in November 2024, based on the AGAVE-201 trial, we now have axatilimab, which is approved in chronic graft versus host disease. We are anxiously awaiting that drug to hit the shelves, and most of us are looking forward to treating our patients with it who still require drugs despite effective second and third line therapy. But when we're choosing an agent in second and third line, it's quite difficult, in fact, because on paper, most of the drugs actually look quite similar. They're all associated with response rates in the 70 to 75% range, and they all have very low complete response rates. And that's because these drugs are being given to patients who have fixed changes of chronic GvHD that probably are not reversible. Most of the drugs have been tested in pediatrics. Everything works better in children, which is great for them. So response rates tend to be higher. And some of the drugs are approved in ages as low as 1 year or greater. By and large, these drugs are very well tolerated. However, they do each have a unique set of side effects and off-target effects. I think most of us recognize that, unfortunately, ibrutinib at the 420 milligram dose is the least well tolerated of the 4 drugs that we currently have available. It's associated with more fatigue, more diarrhea, and perhaps an excess of infections. And of course, one has to remember about the cardiac conduction defects and be cautious in using ibrutinib in patients with prior cardiac disease or arrhythmia. Ruxolitinib, by and large, is very well tolerated, but does have a class effect side effect of causing thrombocytopenia, anemia, and leukopenia. This is because the EPO receptor and the TPO receptor both signal through JAK-STAT signaling pathways. And so while it's a side effect, it's actually anticipated and what we would consider an on-target side effect of ruxolitinib. It often requires some dose de-escalation. That being said, even at lower doses, ruxolitinib certainly can be effective in the management of chronic graft versus host disease. Belumosudil at this moment is the best tolerated agent that we have in chronic graft versus host disease. Side effects are rare, and discontinuation rates of belumosudil are extraordinarily low, both in clinical trials and with the real world evidence. In the Rockstar study, the 3 side effects that occurred greater than 5% at a level of incidence of grade 3 or higher were pneumonia, hypertension, and hyperglycemia. And these are side effects that patients with chronic graft versus host disease typically have. We have the least experience with axatilimab because that drug, of course, is just coming on market. It has a unique side effect profile with 2 important classes of side effects. The first being some atypical periorbital edema, which is generally harmless, but does sort of frighten the patient. And then a series of elevations in serum enzymes such as ALT, alkaline phosphatase, lipase, and amylase. And this is because the Kupffer cells, which generally are used to take these enzymes out of circulation, are depleted by the monoclonal axatilimab antibody. And so just to summarize, belumosudil is probably the best tolerated, ruxolitinib coming in second, ibrutinib third, and the real world, we've yet to see how axatilimab will fit in terms of side effects. There will be a learning curve to understand how to manage these side effects in chronic GvHD patients. So when we do start these drugs in second or third line, there are, of course, side effects that we expect, and there are some strategies that I use and that the field uses in general to try to get around them or mitigate the effects. Ibrutinib with fatigue and diarrhea generally requires dose interruption until resolution of diarrhea and fatigue, and then I reinstitute ibrutinib at a lower dose, either 280 or sometimes 140 milligrams per day, and gradually work back up to the maximal tolerated dose that patient can take. Ruxolitinib generally doesn't require dose delays in the context of neutropenia, anemia, or thrombocytopenia, but definite dose reductions. So in chronic graft versus host disease, we use 10 milligrams twice daily. In general, I'll dose reduce right down to 5 milligrams twice daily. And if that's not enough, 5 milligrams once daily, and that might actually be an effective dose in chronic graft versus host disease. Belumosudil was really only approved with a 200 milligram dose, with the exception of those patients who are on drugs that interfere with its metabolism, like the proton pump inhibitors. In general, there are no dose modifications that I recommend for belumosudil. If the patient has a very important adverse event, such as elevation in liver function tests, then that requires a drug discontinuation. And then for axatilimab, one definitely has to withhold doses and delay subsequent doses depending on the level of transaminase, amylase, or lipase elevation until those levels come down to ranges that are a little more acceptable. Axatilimab is approved at the lowest dose that was tested, 0.3 milligrams per kilo. And so there are no dose modifications that we recommend, but rather dose delays in the setting of toxicity. I think it's important when we're treating our patients with chronic graft versus host disease that we have to remember to keep them on their infection prophylaxis. It's my practice to continue antiviral prophylaxis with acyclovir or valacyclovir throughout the length of the patient's immunosuppression. I also keep patients on trimethoprim or atoloclone to prevent PJP pneumonia throughout. What we have learned is that we don't require antifungal prophylaxis, except for patients who are on chronic higher dose corticosteroids. And so for the most part, I do not use azoles. And one good reason to not use azoles is because of their drug interaction. Most of us take a very algorithmic approach to the treatment of chronic graft versus host disease now that we have several drugs. We almost always start with corticosteroids, and I would say 90 to 95% of us use ruxolitinib in the second line setting, with the exception of patients who happen to have B-cell malignancies, where sometimes I actually will choose ibrutinib as the preferred second line agent because perhaps it will provide some prevention of relapse control. That being said, we know that a couple of the drugs, such as belumosudil and axatilimab, really do have antifibrotic activity, and therefore many of us choose these agents over drugs like ibrutinib or ruxolitinib in the presence of deep sclerosis, fibrosis, or bronchiolitis obliterans. Following failure of ruxolitinib, 90+ % of the market then moves on to therapy with belumosudil in the third line. There's again a few patients that move to ibrutinib in the third line, but now we do have axatilimab, and the question will be, which will be the drug that will be preferred in that setting? I still think belumosudil will be chosen the vast majority of the time because it's an oral agent as opposed to axatilimab, which must be administered intravenously every other week. Unfortunately, we still do have patients who are steroid and novel agent refractory. And for those patients, we need to continue to develop novel agents. So there are certain drugs that are under development. There are drugs that hit the JAK-STAT pathway, including some that have multiple JAK targets, like baricitinib and pacritinib. There are also drugs that are novel BTK inhibitors that are FDA approved in the management of B-cell malignancies that might become useful in the management of steroid-refractory chronic GvHD, particularly in those patients who are intolerant to ibrutinib. And then we now have oral analogs of axatilimab, so small molecule inhibitors of the CSF1R receptor that are being tested in clinical trials. We can't forget about some of the compounds that we already have that are approved in other indications. So the B-cell depleting antibodies, the proteasome inhibitors, and even drugs like abatacept, the co-stimulation blockade pathway, that are being developed in patients with steroid refractory and second and third line refractory disease. And then finally, the field of cellular therapy has come to graft versus host disease. We have CAR T cells that are directed against various immune targets, and even some regulatory CAR T cells that can come in and cool off immunologic reactions. Hopefully, we won't need these compounds, but it's good to see that they are being developed for those patients who might need them. So in the future, we are actually looking forward to advances in the chronic GvHD space. We are very excited about novel developments and the way we now have really a plethora of agents to use for our patients. Most of us feel that with novel agents in our hands, getting patients off corticosteroids and preventing the long-term morbidity of chronic steroid use is really quite important. So most of us will move our patients to second and third line therapy a little bit earlier. We are learning in the real world setting that there is a possibility of combining agents when necessary. None of these combinations have been formally tested yet, and they are considered off-label, but there are evolving publications using drugs such as belumosudil and ruxolitinib together in combination. Both these drugs hit different targets, And so I would advise investigators to get their own experience and determine their own comfort level, understanding that these are not on label and should be done with caution. We are very excited that the world of chronic GvHD is changing with novel prophylaxis regimens and hopefully a lower incidence of chronic GvHD. And I think our biggest challenge as chronic GvHD investigators is really determining which drug is the right drug for the patient in front of you. And for that, we're going to need things like informative biomarkers to tell us which pathway we should be targeting.